So thank you all for coming at short notice to this important address by a keynote by Secretary of State for Health and Social Care, particularly a welcome here because of the obvious gravity and importance of the current situation, and because of our own interest and role as an institution in the health and social care debate. And for those who haven't yet seen it, just to say that our outstanding health and social care unit, headed by Robert Eade, we've produced our own list of principles, policies in our series, What Do We Want from the Next Prime Minister, Health and Social Care. Further copies available, as I say, at the back for anyone who may not have seen it so far. And in this important paper, we've called for a slimmed down set of priorities, both for the immediate term and for the longer term. 8 proposals for each, and obviously these will be reflected upon in the issues around them in the remarks of Secretary of State for today. He's very kindly also agreed to answer questions afterwards. So usual House rules, no question too outrageous. You just have to state your name and or organisation first. So thank you for coming here today, as I say, most timely and in light of this subject of the highest of national issues of national importance on the public policy agenda. We're especially pleased you're here with us today. Thank you.
Well, good afternoon, everyone. Thank you, Dean, for that introduction, and thank you, Policy Exchange, for hosting this speech ahead of the appointment of the new Prime Minister and the return of Parliament next week. And over the summer, we have made progress on a range of issues in the Department of Health and Social Care, including interim payments for contaminated blood patients, launching an international recruitment task force, securing the first bivalent COVID vaccine, expanding the flu and COVID cohorts to the over 50s, consulting on a retire and return scheme for doctors, dentists and senior nurses, publishing a women's health strategy, launching a national mission on dementia, and unblocking enabling works for a range of new hospitals, just to name some of the activity that has been underway. But today I want to focus on our preparation for the inevitable winter pressures and outline wider opportunities for the NHS within the context of someone returning to a department 4 years after last serving in it, and who has been able to view it in the interim from the Treasury, the Cabinet Office, and as Chief of Staff in number 10. And of course, to do so as we emerge from the pandemic, which has hampered the progress which the NHS and social care system was making prior to that. So first, let me turn, Dean, to winter and the number one priority for the department and for NHS England, which is ambulance handover times. And you'll have seen this is not just my number one priority, but from the recent viral video with my heckler, that this is also a big, wider priority as well. To tackle the problems, we are bringing a new focus on operational performance underpinned by data. A small number of trusts account for almost half of ambulance handover delays. And so targeted work over the summer has been focused in particular on these trusts, including building capacity in emergency departments, introducing pre and post cohorting and observation areas, supporting emergency department triaging, and the risk assessment across the hospital as a whole. Yet the issues are not totally within those hospitals' own control. Some actions sit with the ambulance trusts, such as variance in conveyance rates or different performance on call handling. Some will sit with integrated care boards, such as providing a single point of access for paramedic crews, particularly when dealing with the frail elderly. Others will sit with care homes, such as innovative equipment. I had a demonstration on one visit with an ambulance crew of the Manga Elk lifting cushion. Of course, other brands are available, but it shows how technology can speed up how quickly the frail elderly who are on the ground can get back on their feet. And some of these issues sit with NHS England itself in terms of how it prioritises national funding. A lack of flow within our hospitals is also driving ambulance delays, as if those in A&E cannot access beds and wards, it in turn prevents ambulances dropping off patients. And we currently have over 12,000 beds occupied by patients who are medically fit to discharge. Now, this is also resulting in poor patient outcomes, in particular with the frail elderly, because patients often deteriorate if they remain in a hospital bed for too long. So over the summer, we have been working with an NHS England task force to put in place best practice interventions. And crucial this winter will be the effective operational performance management to identify where accountability sits for delayed discharge in a complex system. This includes the level of integration on social care, including care homes and at-home care. It also includes tackling problems within the NHS's own control. 1/5 of delays are due to NHS community services, and another 1/5 due to NHS hospital delays. So, for example, looking at plans around lower weekend discharge rates, specific action on conditions like dementia, Parkinson's and palliative care, the delivery of long-term plan commitments on mental health, and of course the 7,000 additional beds which NHS England has asked for in the community. Capacity is also key to addressing the important issue of cancer backlogs. With urgent care referrals now at 118% of pre-pandemic levels, and the growing number of targeted lung health checks, we need to make a significant uplift in diagnostic capacity to match this. Now, the rollout of community diagnostic centres, we've announced a further 7 today, are a key step in doing so. But these take time to open. So we also need all trust to prioritise the 3 cancers which account for 2/3 of current delays in diagnosis, which are skin, prostate and gastrointestinal, and on which there is too wide a variation, particularly with the bottom 20 trusts. Integrated care boards will also need to prioritise new cancer pathways, such as through pharmacy and community referral. Now, alongside ambulance delays, a second dominant health issue is clearing the COVID waiting list backlog. And over the summer, the 2-year waits were virtually eliminated, with a final 2,000 cases set to be resolved by the end of September. We have accelerated key programmes, in particular Professor Tim Briggs's Get It Right First Time programme, with quicker patient routes to surgical care, supported by the additional 50 surgical hubs announced last week, alongside the existing 91. In tandem, we are shifting more operations from the operating theatre to outpatients, with the Right Place, Right Time programme. An example, when I visited Homerton, was that they told me they are delivering 3 times the productivity rate on certain gynecological procedures in outpatients than if carried out in the operating theatre. There is also low-hanging fruit from addressing variation in performance. Let me give you an example. If all operating theatres move to 85% utilisation from the current average of 72%, as indeed the Get It Right First Time team recommend, then that alone unlocks an extra 410,000 operations a year. This extra capacity, including from the surgical hubs, will be crucial in terms of resilience, given that in each year since 2015, operations have been put on hold as winter pressures mount. The adoption of surgical hubs, therefore, as standalone sites, helps mitigate against this risk. We also need to make sure that patients are able to exercise choice at the very start of their care. And that's why more choice will be offered at the point of GP referral. It's not just about the right to choose a hospital with a shorter wait, but we need to make better use of the NHS app so patients can organise appointments in a seamless way, as in other parts of their lives. For operations like hip replacements, currently patients face average waits ranging from 6.8 weeks to 34.4 weeks. So we should empower patients with the choice to travel if they are willing to do so. Empowering patients is also part of addressing GP access concerns. There are over 6 million GP registrations a year, with early testing suggesting online registration reduces processing time by 15 minutes for each application, as well as improving choice and convenience. So we will lay a strategy instrument next week to amend the GP contract to enable this. Significant GP time is also taken as a result of the interface with secondary care. And we have prioritised work over the summer in terms of how we reduce this burden for GPs, including prescription requests from discharged hospital patients. We are also working with NHS England to determine how additional flexibility could be brought into the additional roles reimbursement scheme in primary care networks, so we can free up GPs' time where possible. Now, integrated care boards also need to continue to demonstrate how the increase in over 24,000 new staff in mental health services since March 2016 is set to grow further over the coming year, and how the 2.3 billion real terms annual budget increase by next year are starting to shift the dial on mental health services. We know the pandemic has seen an increase in demand for mental health services, and that we need to prioritise mental health going into this winter. The NHS has responded to this by expanding community and crisis care mental health services, and it has helped keep stable the emergency attendances to A&E for mental health concerns. This includes a rapid rollout and expansion of community-based crisis services, and there is now a complete coverage 24/7 of crisis resolution and home treatment teams across the country. That is bringing care closer to the home into a more therapeutic environment and reducing pressure on hospitals. This means we are treating more people now than ever before. Use of digital products with the best evidence of clinical and cost effectiveness can also greatly help with the management of demand for mental health services. NHS England have found a low level of awareness of this work, and I share their desire to see it more widely promoted. Now, those have been key immediate priorities over the summer, but I've also been examining the opportunities for the NHS in the future and what we need to do to grasp them. Now, workforce is, of course, critical for both the health and social care sector, and we need to act fast to address the high number of vacancies. That is why we have set up an international recruitment task force, and it's also why we need to think more about retention, given it is a cheaper way to retain a clinician than to train a new one. By way of example, it takes 10 years to train a GP, but currently around 500 GPs aged 55 to 59 leave the profession each year. Now, there are clearly a range of options that are being publicly debated on pensions, which colleagues in the Treasury will wish to consider, and indeed I have discussed with them. Last week we launched a consultation on a retire and return easement to encourage staff to return given the pressure expected in the months ahead. We also need to make sure that we use the workforce we have as flexibly and efficiently as possible. And I've been hugely encouraged to see the excellent work being done as part of the forthcoming workforce strategy and workforce plan. And we need to see new roles, such as advanced practitioners, embedded in the NHS. And we need to see more staff practicing at the top of their licence. We are also taking targeted action in specific priority areas, for example, investing 127 million to increase and support the maternity NHS workforce and increase neonatal care capacity over the next year. And this is on top of the 95 million investment in the recruitment of an additional 1,200 midwives. We should also continue to push for more decentralisation of NHS services away from hospital sites where that is appropriate. A key objective of the government is to level up, including in communities with poor health outcomes, which often have a significant journey time from their nearest major hospital. A good example is community diagnostic centres, which bring treatment often closer to the home and which have so far delivered 1.7 million tests. There is also scope for more home testing, and I have commissioned the department to consider how we embrace home testing for a wider range of conditions through a modernised health check. And I can announce today that I've asked Professor John Deanfield to take this work forward. Now, one consistent priority of successive Secretaries of State has been the greater use of technology, including areas like machine learning. And we need to ask ourselves why it has seemingly been so difficult to scale innovation, with many pilots commissioned, but those that are successful not always rolled quickly across the entire NHS. Now, in practice, NICE is already breaking new ground. Together with NHS England, they are working to develop a policy framework for an early value assessment for digital health technologies, which can also be applied to medtech. And this policy framework will greatly improve the uptake and adoption of well-evidenced technologies and provide clarity to industry partners of their route to scaling and reimbursement. And again, I have written to NICE asking for this work to be expedited. Turning to the longer term, we need to act on the large number of priorities being set by the centre, many of which are not measured in a way that supports individual accountability. Now, I've got the sense, I may not be alone in the room, that over the years the NHS likes to hire McKinsey's. And I think it was McKinsey's which said that, quote, "You cannot manage what you do not measure." By way of example, I replied earlier this month to the recently launched Health Select Committee investigation into digitisation in the NHS. And was somewhat surprised that the attachment to my letter shared with me by the department ran to 20 pages, all with past commitments that were worthy, but clearly some are more urgent priorities than others. And yet for all the priorities, when I visited North Warwickshire Hospital Trust, a major trauma centre, a leading surgeon told me how his team often sit around on a Monday morning waiting for images to load. So ensuring all trusts have effective Wi-Fi and patient electronic records should be part of prioritising fewer but more impactful issues. We therefore need fewer central priorities which free up more local decisions with a focus on those that are most impactful and scalable. For example, at the national level, my focus on ambulance handover times will improve patient flow, which will help improve care for anyone in need of hospital treatment. We also need to have better alignment in priorities between the department, arm's length bodies and ICBs, and ensure there is a focus on delivery and accountability. This is not about relaxing core NHS standards, but clarifying the performance management of those standards to enable meaningful accountability. A key driver of the large number of priorities is the size of the centre. Now, both leadership candidates for Prime Minister, as former Chief Secretaries themselves, have signalled the need for efficiency savings across Whitehall. Given the Department of Health and Social Care is expected to account for £4 in every £10 of day-to-day government expenditure in the near future, it is a natural place to start to identify what can be reprioritised to meet frontline pressures. The Department of Health and Social Care and its arm's length bodies cost £2.8 billion a year to run. The department itself employs 4,335 staff, with a pay bill of £260 million and estates and other costs of £125 million. And NHS England, 13 arm's length bodies plus several other similar bodies together employ a further 37,200 FTE, with a payroll of £1.9 billion, an estate and other costs of £470 million. In addition, the 42 new integrated care systems have 25,000 staff transferred earlier this year from clinical commissioning groups, and there is a further 7,000 in commissioning support units. So even if you exclude arm's length bodies like the NHS Blood and Transplant Service, where staff support blood and organ supply to hospitals, if you exclude the CQC, which has inspectors playing a key role, just across the ICS, the CSU, That's 32,000 department, 4,300, NHS England 10,117, NHS Digital 3,950, HE 2,985. That equates to over 53,000 staff in organisations where the majority are not providing direct patient care. That's in addition to the actual management within hospitals, community settings, primary care and health research. That is additional to that. And my point is, this is not just an issue of cost. It's also about effectiveness. Because too much management can be a distraction to the front line. Staff at the centre need to streamline the administrative burden of those on the front line and not risk adding to it. And if we are to reprioritise back office costs to the front line, there needs to be more transparency. So in my first week as Secretary of State, I commissioned the first ever digital map of the department. And this was initially extended to the 8 largest arm's length bodies and has now been applied to the remaining 7. I can announce that the department will publish its organogram on Monday with a searchable format to follow shortly afterwards. And I have instructed all arm's length bodies to do likewise in publishing a searchable organogram by the end of September at the latest. This will show all job titles and the number of people working in each team. And I have asked the departments and arm's length bodies to add by the end of September the cost of each team reporting to director level. This will enable those within the NHS, as well as those outside, to better understand how this £2.8 billion is being spent, and in particular to empower NHS staff to identify whether this funding is being spent in areas that are most helpful for them in terms of delivery on the front line. So it will stimulate, I hope, a conversation within the NHS about how priorities and resourcing is best aligned. In the meantime, I have put in place a recruitment freeze in the department and set the expectation across arm's length bodies and on consultants and contingent labour. I've asked the department to review all contracts this year with a view to a minimum 20% saving, with the expectation of going further this year, in some cases 80% saving, informed by contract analysis, and I'm hugely grateful to Lord Agnew for the support he has given in this area. This would unlock £170 million at 20% savings across the department and arm's length bodies as in-year savings this year, with much more scope for higher savings next year, given that obviously we've already lost 7 months of this year in terms of the saving opportunity. Finally, I want to turn to an area of potentially greatest saving, and indeed one that unlocks improved operational performance, following specific changes I've agreed with the Treasury over the summer, and that is how the NHS procures its new hospitals and in time wider buildings within the NHS estate. Now, when I was in the department 4 years ago, I visited the Midland Metropolitan Hospital in Birmingham shortly after the collapse of Carillion, something I'm sure some in the room will remember. And I was surprised to discover on site that even the bathrooms could not be built to an off-site modular design because each one was a slightly different size. In the past, each trust executives have been largely free to embrace unique or varied designs. And indeed, if you look at the last 10 hospitals built, 9 have seen significant cost overruns and delays. And that's not just a cost issue, it means the benefits operationally of those hospitals are delayed for staff and for patients. Allowing trusts to design and procure bespoke hospital buildings frequently results in poor scoping work before contracts are awarded, contracts awarded at too early stage, meaning too much risk is priced in, and trusts with little or no past experience who are simply not geared up to build complex schemes. And in turn, bespoke designs require more work in terms of their approval process, including from Treasury, whereas greater standardisation can streamline that process. So applying a standard design and specification, the Model Hospital 1.0, allows greater cost price certainty with factory build, economies of scale through standardisation, and quicker on-site construction. And in turn, this means the operation benefits of the new buildings are unlocked much sooner. Put together, the steps we have taken, whether on estates, on the other areas that I've set out, will enable the department to finish the summer better prepared for the winter ahead. And although the winter will be challenging, we should be confident there are opportunities to improve the NHS and social care system beyond it. Reducing the size of the centre and the large number of priorities which result, so that local leaders can better focus on what matters most to their locality. Data-driven performance management focusing on addressing variations, whether on the ward or on delayed discharge or when building new hospitals. Patient empowerment through choice at the point of GP referral and better use of the NHS app and home and community testing. And scaling innovation so we adopt the opportunities of tech in a way COVID showed could be done. In conclusion, the NHS demonstrated during COVID its ability to move at pace, adapt and innovate. And within Whitehall, different ways of working, as we saw on the Vaccines Task Force workforce, showed that schemes could be delivered in a more agile way. Whilst COVID has left us with challenges, in particular the elective backlogs, it has also shone a light on the way that we can deliver differently, which will be essential if the NHS is to meet the immediate challenges this winter and those in the longer term. Thank you very much.
Great, thanks very much. I'm sure many questions. Just if I could ask anyone who wants, I think there is a substantial online audience as well, if people could please be so kind there to stick up their virtual hands. Who do I see asking first a question, trying to get a flavour? I know a lot of people will want to. Lady there in the front row, if you just give your, somebody can come forward with the microphone, thank you. If you give your name and organisation, please.
Hi, Laura Donnelly from the Daily Telegraph. You've made the case for fewer central priorities. I wondered, could you clarify and give us some specific examples of what you would take out or what you would recommend are taken out of the central priorities? Because there's been quite a lot of speculation and sort of reporting about what might be involved. And just a second quick question. In terms of the recruitment freeze in the Department of Health, can you give a sense of what scale of savings you think might be achieved by that?
So I think firstly, you know, as I set out in the speech, the NHS core standards are there, and that's sort of the key test. But I think if you have a very large centre, if you have people both in the department, NHS England, other arm's length bodies, in the regional bodies, that generates lots of meetings, lots of people with different priorities. And I think what gets lost sometimes within that is what delivers the biggest impact. If everything's a priority, nothing is a priority. And so the point is saying within that, so the example I gave was on digitisation. If you have 20 pages of digitisation priority, but a surgeon is sat waiting for images with a team, which was the experience on one of my visits, then I think we've got to say within those 20 pages, all of which is worthy, local leaders will often be able to say what best suits their locality, but within the centre, we then need to work with key colleagues on what delivers the best bang for the buck within the wider noise that is sometimes generated. And then within that, disaggregate who is responsible. So for example, earlier this week I was talking to the National Cancer Lead as to what sits with NHS England on cancer, what sits with the ICBs, what sits with the trusts, because as I said in the speech, you've got 20 trusts that are outliers at the bottom, and we need to know what is in the control of those chief execs, but then what is out with their control where they need the ICS or they need an NHS England programme to support. So that's what I'm driving at, is to say, so, you know, I was very clear, my number one priority over the summer has been ambulance handover delays, because I think it's about much more than just ambulances. Firstly, it's about the unmet risk in the community. If an ambulance doesn't turn up, you know, for a long period of time, that's an unknown risk. But also, it's about the flow in the hospital that comes, and the interlinkage with delayed discharge. And what you get if you speak to a trust chief exec is Some of the things are within their control, but some of the things are within the control of others. And I think what we've been trying to do with the performance data is start to use real-time data to better pinpoint where accountability sits within priorities.
A couple of specifics. I think that's where the confusion is in terms of what would you think personally shouldn't be a central priority?
Well, it's about where priority sits. I've said on digitisation, a whole range of things, and saying from the centre, there's clear NHS core standards that apply across your maternity, cancer. I saw the story this morning. You have that, core priorities within the NHS standards. What I'm saying is the larger the centre, the more meetings that generates, the more top-down. And when I talk to trust leaders, one of their frustrations has been the amount of time that is spent dealing with the centre. And I think you can say there's lots of things. There'll be individual charities who that will be a particular priority. Well, that priority will really matter in one locality more than another. And trying to say every one of those is a priority at the centre, actually, I think then confuses what is the true priority.
It, but I just mean if you looked at 20 pages, was there nothing that jumped out like, really, we should ditch this one as the central priority?
Well, I mean, you can see it. I shared it with the House Select Committee. So read what I shared with them. What I'm saying is there's lots and lots of small things. For a particular audience, that scheme will matter, but that is much more what an ICS will decide in terms of what matters for their locality. And it comes to my wider point, which is part of levelling up, we should be more place-based. And we should allow local areas to determine and have greater control of those and set at the national level, here are the core standards, but in particular, what sits with the lead in, if it's mental health with Claire Murdoch, as the lead within NHS England, what sits with her and her team versus what sits with other bits of the system. And at the moment, certainly in the department, often that performance data to enable that accountability is not where it needs to be.
Okay, thank you. I see many other questions. Gentleman there in the second row. Name and organisation, please.
Hi, Sean Linton from the Sunday Times. Secretary of State, the problem with ambulance handover delays that clearly concerns you has been an issue for the NHS going back into the early summer of 2021. Many tens of thousands of people may have come to harm, according to the Association of Ambulance Chief Executives. I'm interested to understand from your position, given that, why has more not been done by the department and your predecessors to get us into a better position now? And isn't it too late to prevent a system failure in the coming months as winter starts to bite?
Well, I think firstly, to be fair to predecessors, we've just been through a global pandemic and that placed huge strains on the system and we're dealing with many of the consequences of that. So I think we've been through a particularly demanding time. If you look at the responses on ambulances before the pandemic, obviously things were in a much better place than they are now. So it's clear the pandemic has been a significant factor. But I think what I'm driving at, Sean, which in the previous answer, is there are a combination of factors at the heart of what is causing slow ambulance handovers and ambulance delays. One of the key ones is delayed discharge. Now that often is factors outside the hospital trust chief exec's control. That may be, very frequently that is about what's going on in domiciliary care and social care. And that's why the government has prioritised funding to social care and why the department's been integrated as the Department of Health and Social Care. So I think if, Simon Stevens and Jeremy Hunt from their time when I was last in the department were talking about the importance of integration. The very essence of having the integrated care system is to recognise that this is an integrated system. So people visually see the consequence in terms of ambulances, but actually there's many other factors that are contributing to the ambulances being delayed. Discharge is one. The question is where risk sits in the hospital. Do you take some more beds on a ward? That often is very difficult, puts pressure on, particularly on the nursing staff if you do that. When we had the heat waves, Stephen Powers wrote out with Ruth May to hospitals on that issue, but that is a difficult issue. It's a question of emergency department capacity. So when I was Chief Secretary in SR20, I signed off significant extra funding to boost capacity in emergency departments because that's an issue. There's then innovation, so whether with the fire service, what I went and looked at in Hull, looking at frail elderly schemes. We've got St John's Ambulance, where we've just announced 30 million for them. Then there's the issue on call centres, and we put an extra 50 million in to call centres to boost those in terms of the increased volume. Then there's pressure on the ambulances themselves. We put 150 million in to support there. There's questions of fleet and how. So there's a whole range of issues, and I think what we've been trying to do is disaggregate what is within the Ambulance Trust Chief Exec's control. So is there variation in see and treat, hear and treat, and understanding that, you know, what is within the trust control, what's within the hospital's control, what is it, you know, it might be weekend discharge dropping in a hospital because the consultants are not there on a Saturday, whereas the hospital down the road, they are. So understanding what's within the hospital's control. There's certain things, like I said in the speech, that drive particular long delays. So dementia, Parkinson's, for example, and looking at bespoke programs there. Then there's also the join up with DLUC colleagues, which again we've been doing work on over the summer around the social care capacity. Do we have beds but not the workforce, hence the international recruitment. So there's many factors, but it very visually manifests itself in terms of the issue of ambulances and whether they're stuck at hospitals.
But given that complexity, is it too late now this winter to prevent a system failure?
Well, part of the reason, you know, both Amanda Pritchard and I have said, you know, this is our number one priority, and we've been working, you know, very closely in tandem over the summer, and with key people like Anthony Marsh, who's been fantastic in terms of the work that he has been doing, is to say we recognise there's a challenge, you know, and we're working extremely hard, Sean, to address that. The point I'm saying is there isn't a magic bullet. It's not just one factor that is at the heart of what is causing the ambulance delays.
Thank you. Lady there, second row, lady. Give your name and organisation, please. Wait for the microphone so we can hear.
Thank you. Hi, Ali Fortescue from Sky News. You just said you want to allow local areas to determine their focus on some services. Could that potentially lead to a postcode lottery in areas like maternity services, mental health, cancer? And secondly, can I ask, what do you think of Liz Truss's suggestion that some money should be diverted from the NHS to social care? Is that something that the NHS can afford?
So first, you know, I was very clear that the core NHS standards apply, and you know, a big part of my diary, so with whether it's meetings with Claire Murdoch on mental health, or you know, earlier this week with Callie Palmer on cancer, is focusing on these issues. A big part of the speech. I know there was a paragraph in one of the stories this morning, but you know, we're very clear those are the priorities. I think what I'm saying is, if everything is a priority, nothing is a priority. If you have 20 pages on digitisation, my point was what within digitisation delivers you the best bang for the buck, and then how you're working with ICSs who are, you know, new organisations, will take time to be fully sort of fledged and established. How we're working with them in terms of which things for their locality deliver the best impact, and particularly, and this issue goes back to when I was in the department 4 years ago, which is how we scale innovation. Because what you see quite frequently as a minister, not least because your ministerial visits will often take you to a place that's doing something very well. And it then begs the question, okay, where else can you scale that across the system? And that's why I'm very keen for NICE to play a more active role, and they're already working in the space, around how we take innovation and scale that across. So to give you an example, in Leeds, they've got a very good innovation hub lab that I went and visited. And I was saying, well, who then fast tracks that through the NHS system? And to some extent, the innovator is then tasked with scaling that through. And I think there's a lot more we can do to help pull that through the NHS. So we do that at pace. And what's the question, sorry, on the leadership?
About Liz Truss suggesting she wants to divert funding onto social care. Is that something the NHS can afford?
Well, I think what I signalled in the speech is just how important social care is. So if you take the issue of delayed discharge, then at the heart of that is the challenge around social care. And do we have the domiciliary care packages? Do we have the right level of care in care homes? What is it? Is it beds? NHS England have written out in terms of additional beds, virtual wards. Is it workforce? Part of the reason for prioritising the international work was around that. There's obviously discussions, again, I don't want to upset Treasury colleagues, but the discussions in terms of social care more widely, live discussions around retention. So there's a whole range of things. So I think what was signalled with it becoming the Department of Health and Social Care is how integrated social care is to the challenges that the NHS face. And I think that's one of the key things both leadership candidates have been clear on.
And just to get a flavour, I know an awful lot of questions also the glare of the lights in my eyes. I see some people online just, I see Dr. Farzana Hussain, GP from the Project Surgery. Can you hear me, Dr. Hussain?
I can. Thank you so much. Can you hear me?
Yes, loud and clear. Please, if you just speak up so we can hear you.
Thank you. So I'm Dr. Farzana Hussain, GP, here at the Project Surgery in Newham in East London. Thank you so much for your speech. My question was, I completely agree with you about scaling innovation, but I wanted to know how you think that could happen, because at the moment, some of us are fans, and then we do something, and most of it is in our own time. And I have to say, I haven't even managed to scale some of the innovations I've made in my small 5,000 list size to my primary care network of 67,000. Do you think there should be more time, resource, and more position for this sort of scaling and quality improvement that you're talking about, given the facts you were saying, fascinating, that actually half the number of ambulance handover times are for a small number of trusts? And do you think we can improve the culture where sometimes as health professionals we do feel that we're named and shamed, and how can we do that more positively? May I just have your advice on that? Thank you.
Just come in 1 second. It's Stephen Black. Sorry, can you hear me, Stephen Black? Can you hear me?
I can hear you.
Yeah,
yes.
if you just say which organisation you're from, so Secretary of State can take the sort of double question from those who are speaking.
Okay,
offline.
I'm an independent healthcare data scientist. My question is, the NHS has about half of the capital employed per member of staff of any other European health system, as a result of spending half the amount of capital every year over the last 20 years of almost any other comparable system. And that affects things like the computers that are used to support doctors, the quality of the buildings, the number of diagnostic machines we have. What can be done to ensure that the capital budget is sufficient and protected so that in future we have the right number of diagnostic kit, the right number of diagnostic machines, and the right level of quality hospital facilities, and the right amount of computers for doctors?
Right, well, I think it's a very good question. So first on the scaling, I think part of the reason for writing to NICE is I think actually NICE has a key role to play in the way that they do, world leading in terms of their approach in terms of drugs. And I think there is a greater role for NICE to play in terms of how we work with innovators and manufacturers to get the right level of data, and therefore de-risk for trust. Because again, one of the conversations that really stood out for me from one of my visits is how different trust boards individually will make a risk assessment. And I think the more we can then address that from the centre, Dean, the more you can de-risk it for areas to scale out. So that is something that it's a piece of work that I've commissioned from NICE, and I think there's opportunities for us to go further. And obviously, I think there's huge potential on medtech. It's also something in my previous role in the Cabinet Office, we were doing a huge amount of work through our AI strategy and machine learning. And again, for an NHS where workforce is under pressure, thinking about what are the opportunities in terms of taking some of that pressure off workforce through machine learning, and then redeploying that talent into other areas of the system. So I think there's a lot of areas. I think what I was recognising in the speech, though, is this has been talked about for a while. You know, in 2019, we said at the AI Labs, there was work done on that and so forth. So it's not a new issue, but I think given the pressures we've got, COVID has shown we can innovate at pace, and I think it's important that we do that around, particularly on the product side. On the capital funding, part of the reason, and you know, in some ways it's quite a difficult thing to signal the costs at the centre, the costs in one's own department, the costs within the arm's length bodies, and to bring that transparency to it. But because it's £2.8 billion, the question is as funding comes under pressure through inflation, through meeting the pay, the recommendations of the independent pay review body and so forth, it's important that we say where is money allocated currently, and is that allocated in the place that best unlocks patient care. And so I think part of the reason for being much more transparent than has been the case in the past on the costs in the centre is because I think that transparency will facilitate a conversation around what is our tech transformation budget versus what are we spending there. So to give you an example, when I was in the Cabinet Office, I discovered that on science and technology, we had 60 strategies across government on science and technology. So that's really what I'm trying to facilitate, is that conversation within the NHS. So people start to say, actually, where is the impact? And if you unlock a 10% efficiency saving through the electronic patient record, then that seems to me to have a real urgency, both from an efficiency point of view, but in particular from patient care, and then what you can then add on once you've got that electronic patient record. And so that's why I've challenged the department over the 3 years that we were taking on that to say, actually, I think that's a real anchor of innovation and change, and we should be moving at pace on that. And if we then need to have approvals within government that are quicker as a consequence of that, then I think that's the sort of challenge that ministers should take into the system. So I think there's opportunities by looking at costs in certain areas. Again, if you look at on the commercial side, I was just talking to someone this morning, I think it's 39 billion the NHS spends on its supply chain in terms of products. Now there's risks. I remember from the Public Accounts Committee, if you centralise everything, that carries risks. If you think of the fire buy, when the fire service tried to centralise all its procurement, that had risks. But if you look at the very good work, even though it was a Labour peer, but a huge fan of Lord Patrick Carter, and the very good work he did with the Model Hospital, you know, it shows that actually greater transparency can better inform decisions. And so I think if you look at that supply chain cost, having a clearer sense of our inventory, who is buying what, how we're using the scale of the NHS, I think that transparency again can be very helpful. And having someone like Lord Agnew, you know, he's extremely effective at looking at those issues.
Great stuff. I know. I'd say tremendous number of other questions, limited time. I'm just going to get maybe take to class 2 people there, if I can do it in geographical proximity. Lady there in the 3rd row, and then gentleman behind her. Name and organisation, please.
Hi, Sophie Huskisson from the Daily Mail. So I appreciate what you were saying about the recruitment task force, but today the figure shows that the vacancy numbers have hit new highs again. So I wondered what you're going to do like immediately to try and retain staff. Especially, you know, there's a lot of unhappiness amongst staff in the NHS. I know you said you're talking to the Treasury about pensions, but what are you going to do about the pay award and the pay increase? Everyone's very angry about that. You know, we could be facing strikes from junior doctors, nurses, consultants, specialists. How are you going to deal with that this winter?
Sure. So just gentleman behind, sorry, Secretary of State, just because limited time. Gentleman there, if you give your name and organisation.
Jonathan Holmes from the King's Fund. Asking a question on a similar vein, you quite rightly identified that workforce shortages remain one of the key challenges and also rate limiting factors in working through the backlog that built up during COVID. You've identified a couple of policy solutions to that in the short term around international recruitment and pensions. I was wondering if you could give an idea, particularly reflecting on the statistics that were referred to earlier on the new scale of shortages, what kind of impact do you think that might make? And then with a workforce plan scheduled for later in the year, sort of an idea of some of the longer term policy proposals that might include. Thank you.
Yeah, great. So firstly on pay, you know, we're very clear. We have a process with the independent review bodies, which we have accepted their recommendations in full. And in terms of numbers, we've got more doctors, more nurses. We just had an announcement, I think it was this week or last week, in terms of more healthcare assistants, 25,000 as well, being hired. So there's more, but we also recognise there's more demand in the system. And that's why over the summer we put in place the international recruitment, both on the nursing side but also on the care home side. And again, recognising one of the impediments on care, and it comes back to you know, the earlier question in terms of the integration on the nursing and the care side, recognising if many small care homes are not going to go and recruit internationally. So the question then we discussed internally was, how do we facilitate that? How do we make that easier by having a clearing house, which is also important in terms of then being able to have a duty of care to those staff, ensuring that we're looking for abuse in the system and some of the risks that can also come with international recruitment. So there's been work there. There is more recruitment. I think it was when I was in the department last that we announced the extra 5 medical undergraduate places at colleges as well. So that has all been ramped up. What I was recognising in the speech, though, was given the pressures we have this autumn, we need to look at all the options available. So that includes on the retention side, and I gave as one example the impact on GPs, the number leaving, and clearly the Treasury, you know, in preparation for the new Prime Minister, will have a range of things that we will wish to consider. Now, I'm sure you'll appreciate I won't get into those today because these would need collective agreement. There's a process in government. The new Prime Minister will wish to take a view. But we recognise there's significant pressures on the system, and what we've been doing over the summer is not simply waiting for the new Prime Minister. We've been saying, let's look at our international recruitment, let's look at our options on retention. We've just announced the consultation, as I said in the speech, in terms of retirees having an easement in terms of them returning. So there's a range of things. It will be for the new Prime Minister to decide whether in the other issues, which are well familiar, I think, to people in the room, some of the other issues that are debated as to where the new Prime Minister wants to go.
What would you do as Health Secretary now to try and mitigate strikes from happening?
Well, as I say, I think it's important that my advice, both to the new Prime Minister and the Treasury, is done in the way that these things are done in government, which is through collective agreement and internal discussion. So I've had those discussions with the Treasury. There is a process, and that's how it should be. I think the other thing where there is an opportunity is not just on the tech side in terms of things like the machine learning and looking at what we can automate, but also through the new pathways. So if you look at Tim Briggs's excellent work, it's about saying what is the streamlined pathways that we can have. How can we use, for example, home tech to then refer people straight to the person in the system they need? What is the wider range of skills in primary care that we can maximise? Because not everyone needs to see the GP. If someone's got issues, as part of the women's health strategy, when we're looking at menopause, you might go to someone specialist with expertise in the menopause. It doesn't always have to be to the GP. So how are we maximising the wider skill sets? If I look at dental, where again, everyone in the room knows there's significant pressures in terms of dental treatment, are we maximising dental hygienists and the wider skill sets of people in terms of what they can do? So it's using the full skill sets of people, not simply saying it's simply about accessing a GP or a particular clinician.
Okay, thank you. Just 5 more minutes. I just see so many more because some people will be disappointed. Lady there, lady in the far rear of the room on the right side as I look at it. Lady in the there, yeah.
Hi, I'm Kat Lay from The Times. When can the general public expect ambulance waiting times to be back within targets?
And the other lady there at the back, question, if you could retrieve the microphone. So.
Juliet Brown from Libby. Why in 2022 are we still starting most people's health journeys with a panic-inducing and often disappointing 8 a.m. call to a local GP surgery? Why have we failed to change how we organise primary care to take real advantage of the scale and equalising opportunities that technology could give patients and could give the NHS?
Okay, so firstly, I think it's always difficult for politicians to look into the future and second guess what the level of COVID infections will be, what the level of flu will be, what pressure there will be in the system in terms of how that plays into ambulances. What I focused on is what is within our control, which is about identifying where the performance management sits, how we ensure best practice is followed. We've had a delayed discharge task force, a 100-day sprint led by NHS colleagues over the summer, looking at how we do more on delayed discharge and get best practice across the system, because we know that has a key impact on ambulances. So I think what's a fairer response is to say, are we pulling all the levers? Are we identifying all the areas of best practice that address this issue, rather than second guessing what the level of demand will be in a particular month? So I think that's the difficulty there. On the issue of primary care, again, there's certain areas that we've been looking at where we know the best practice. So there's huge frustration with that 8 a.m. call. We know GPs that are putting cloud telephony. That is a very good way of addressing that. I went in East London to look at one of the GP practices where there's huge difference in that, and also some unexpected benefits of that. So one of the examples they gave me was with domestic violence victims. One of the benefits of the callback system with the cloud was that instead of someone having to come to the GP's practice, they were able to contact them at a time that was suitable for them as the patient. So it's thinking about how we're using best practice across the system. Clearly, there's more we can do through apps. There's also work we're doing through pharmacies and how we better use the pathway in terms of pharmacies. If I take blood pressure tests, for example, people don't need to necessarily go and see the GP for the blood pressure test. It's often those sort of things that can be done elsewhere in community settings. And then there's innovation. You know, we've got some very interesting pilots around wearable tech and how that gives data direct to the relevant clinician rather than the pathway being through the GP. So I think there's a number of areas. Part of it is just dealing with where we're starting from. So if I go back to my first example, if you say, well, cloud telephony is hugely helpful, why don't we just apply that to every G practice tomorrow? Part of the challenge is often they're in legacy contracts that are quite difficult to come out of. So it's not simply a case of just saying we've got some innovation here, department, stump up the money, and let's roll it out to everyone, because we've got to deal with the fact that often those GPs are on existing contracts, but what we need to do is ensure that as they come off those contracts, then we're ensuring that they're embracing the right technology, and also that technology is interoperable, where they're interacting with others in the system. And there's things which I didn't put in the speech, but again, you know, Tim Ferriss and Ming Tang and others working on areas like the Federated Data Platform, which is hugely important if you look at Chelsea and Westminster and the findings there. And that really gives voice to what we mean around integration, because you start to see what the data can then show on a place-based. And I think, again, for people not familiar with it, the outcomes from Chelsea and Westminster can give a huge sense of the potential of that. Having data on an integrated basis based on place, I think offers huge potential, which will kick in from April next year.
Final brace of questions. I just see a lot of trying to choose it as fairly as I can in the light of gentleman there, waiting on the right, lady there on the far left as I look at it.
Hello, Henry Anderson, Health Service Journal. Just a couple of questions, if I may.
One question, please.
One question.
Sorry to be limiting
you said
at this.
Ambulance handovers is your key priority, or has been, and you recently met with NHS CEOs to discuss this. What consequences do you think there should be for trust chief executives who can't reduce handover delays over the winter?
So,
just the lady, just on the other side of the room. Sorry to cut across you, Secretary.
Of course.
Hi, Caitlin Tilley from Pulse magazine. Is there going to be any more winter support, and in particular any more funding for GPs? And could you also talk a bit more about the strategy amendment to the GP contract next week?
Yep. So on the first, but I mean, what I'm extremely keen is to work with the trust chief execs, and a big part of that is understanding what's within their control and what's out with their control. And where that's coming from is when I was last in the department, I remember a conversation where we were talking about the United Lincolnshire Hospital Trust, and it was on its 12th or 13th chief exec in 15 years. I remember saying, surely we've got to look beyond whether it's the fold of the chief exec. So the question is, what is within the chief exec's control? Where is the variance with others? What is best practice on a comply or explain? And what are the things where it needs wider support? And that's why there's been, you know, a huge amount of support, particularly as I signalled there. It's a very small number of trusts that drive almost half of handover delays. So we've had programmes over the summer looking particularly at those, but also more widely, what are the interactions at other points of the system? Where does risk sit? How do we disaggregate that? And what is the performance data to allow us to better identify and move at pace? Because otherwise, the person being blamed may not be the person in control of the thing that is causing the problem in the first. So one's got to be clear what is within their control. So it's not about, you know, blaming the chief execs, it's understanding what are their challenges and how do we then get clarity on that. Once we've agreed on that, then you can have performance management to hold individual chiefs for the bits that's within their control distinct from bits that maybe the ambulance trust or others in the system. So that's the nature of the conversations with the chief execs.
Sorry, if they do fail on those measurements when they have the support in place, do you think there should be consequences in those cases?
Well, not just me. I mean, you said it's my number one priority. It's my number one priority. It's also the chief exec of NHS England's number one priority. So we're completely aligned on that. And it is important that there is performance management within the NHS. We're spending, we will by 24-25 be spending £180 billion of public money. It is important. There's accountability, but that's got to be fair in terms of what is within people's control as opposed to the displacement from activity elsewhere in the system. And for that, you need to have much better data and real-time data in order to identify what is being done. So that's the programme of work there. GPs, it's about making it easier for people to register with a GP. So one of the big issues for me, I'm very interested in the customer journey. How do we empower patients? How do we make the interface for patients smoother and easier? I think, again, COVID has shown a real step change in the public's willingness to use online platforms and that people coming out of COVID, I think, again, through COVID, people used to testing at home. And I think you look at the amazing work that Dame Deborah did in terms of bowel cancer and the importance of testing. There's a surge in people having tests there. So I think there's huge potential around home testing and to link that to patient pathways, how we better use the NHS app. I think the NHS app is an amazing opportunity and I think there's a lot more we should be doing to use the NHS app. Obviously from November people will be able to get their test results. That takes pressure off in terms of some of the phone calls to GPs, but I think there's huge potential around the NHS app and one of the things I want to do is make it easier for patients. So that is things like cloud telephony to deal with the ATM call to the GP. It's helping them to know, do you need to see the GP or are there others that can give you the right advice at the right time? And you don't always have to see the GP. And we have a wider skill set in primary care that we maximise to the full. But then we look at the patient pathways and things like the community diagnostic hubs obviously are a huge opportunity again to do things at scale. And likewise the surgical hubs where you can have them on cold sites so you don't, again, when you get the winter surge, you have much greater resilience. Again, these are all ways of actually giving a much better patient experience.
Thank you, and as I say, my apologies to anyone who may be disappointed now. You've been very generous with your time, delighted to be able to host this important contribution to public debate, and not least which I see that actually no one left during the totality of your address, which I always consider to be an important measurement. But please join me in thanking our guests today, and we're looking to continue our conversation.